Good afternoon. I am Rizko Putra Pradana, an internal medicine resident from 11 Maret University, Dr. Muardi Hospital, Surakarta. On this occasion, I will present a case report of systemic lupus erythematosus with Sjogren syndrome, vitamin D deficiency, and moderate depression. Background: systemic lupus erythematosus and Sjogren syndrome are autoimmune diseases that can emerge together. Sjogren syndrome, meanwhile, is an autoimmune disease in which there is a chronic inflammation that clinically impairs the saliva and lacrimal glands. According to WHO, one of the preceding factors of depression is a biological factors, such as physical health. Many studies show a relationship between deficiency of vitamin D and SLE. SLE patients have a higher risk for deficiency of 25-OHD in a condition with low serum C3 and C4 and high anti-dsDNA. Aim of this case presentation. This case was presented because of its complexity, but with the patient condition much better than she was at first consult with the treatments provided. Case illustration. A 24-year-old woman sought a consult with a chief complaint of bleeding skin wound about 7 days before. It started with rashes in the face about 6 months before, itchy with another complaint of joint pain and headache. The patient also had dry eyes, dry mouth with pain, feels gloomy, suddenly woke up while sleeping, easy fatigue, and have no confidence. Physical examination findings were maculopapular rashes, mouth ulcer, discoid rashes, malar rashes, hair loss, joint pain, nosebleed with pancytopenia of hemoglobin 8.4 gram per deciliter, leukocyte of 1,800, and platelet of 5,000. She then confirmed SLE from EULAR, European Alliance of Association for Rheumatology, 2019, score of 22. She also had a Sjogren syndrome that was proven from ACR, or American College of Rheumatology, or EULAR score of 4. The depression diagnosed from HATS or Hospital Anxiety and Depression score of 12, with multiple precipitations and predisposition factors of depression, which are rashes, divorce, and alcoholism. The patient had a deficiency of vitamin D with vitamin D 25-OH total of only 8.1 ng per milliliter. She was then treated with methylprednisolone 125 mg per 12 hours, which then tapered off to 125 mg per 24 hours after 3 days. Then 62.5 mg per 24 hours after 3 days with home medication of MP methylprednisolone 808, then reduced to 8 mg once daily 14 days after sent home. Other medications are cyclosporin 50 mg per 12 hours, hydroxychloroquine 200 mg per 24 hours, CaCO3 3 times daily, ramipril 10 mg once daily, fluoxetine 10 mg once daily, alprazolam 0.5 mg once daily, steroid cream, eye drops, and psychotherapy. And after all of this medication and therapy, her condition then improved considerably from when she was first to consult. Discussion. In this case, noted that 24-year-old women were diagnosed with SLE moderate. According to EULAR 2019, the patient fulfilled entry criteria of ANA-IF positive with a titer of 1 to 320. With immunology criteria of anti-SM positive from the ANA profile with a total score of EULAR 2019 of 22. Corticosteroids are given together with immunosuppressants and antimalarials to control disease activity. Cyclosporin can be used in relapse or refractory SLE with cutaneous and hematological manifestation, which are seen in this patient. Hydroxychloroquine is the anti-malarial of choice over chloroquine because of its beneficial effect and low risk of retinal toxicity. The patient was diagnosed with Sjogren syndrome based on the ACR-Euler classification criteria for primary Sjogren syndrome. On examination of unstimulated whole saliva flow, the result was 0.1 milliliter per minute for 15 minutes. And on examination of the NA profile, anti-SSA was found positive, so that's a score of 4. The clinical picture of Sjogren syndrome in the patient was a manifestation of exocrinopathy in the oropharynx, which caused complaint of dry mouth due to decreased salivary gland production. Monitoring the disease activity of Sjogren syndrome in patient using ESS-DAI or Euler Sjogren syndrome disease activity index and obtains result of 17. Active disease was defined as ESS-DAI of 5. In this case, vitamin D deficiency was found, hence the patient received vitamin D supplementation. Vitamin D deficiency is one of the factors associated with SLE. Vitamin D deficiency has a high prevalence in SLE patients due to avoidance of sunlight, photoprotection, renal insufficiency, and the use of medications such as glucocorticoids, anticonvulsants, antimalarials, and calcineurin inhibitors that alter vitamin D metabolism or decrease vitamin D receptor function. Vitamin D supplementation has immune inflammation modulating effects that may be beneficial for the musculoskeletal and cardiovascular manifestation of SLE. In this case, the patient was diagnosed with moderate depression according to Hospital Depression Scale or HADS and Beck Depression Inventory or BDI scores. Precipitation factors in this patient is a rash on the skin, with predisposing factors being the incidence of divorce and alcoholism. While the aggravating factor in the patient is joint pain, Recommendation from the American Psychiatric Association or APA for the management of depression in adults are second generation antidepressant and psychotherapy. Conclusion. From the anamnesis, physical findings, and laboratory findings of the patients, diagnosis has been made as an SLE grade moderate, Sjogren syndrome, vitamin D deficiency, and moderate depression that has been treated and resulted in better condition than at the first consult. A complicated disease of SLE along with another disease should be treated and diagnosed carefully. Multidisciplines involvement for each disease should be done. That's all, and thank you.